All right, you guys ready to get started? All right, so diastolic function. So this is a really interesting topic. 50% of heart failure is diastolic heart failure. It's not just decreased systolic ejection fraction. And diastolic function can be very helpful for a couple of reasons. Number one, it gives you a baseline understanding of the physiology of your patient's cardiovascular system. So you can really titrate your therapies based on, or limit some of your therapies based on their diastolic function or dysfunction. And then lastly, you can use diastolic dysfunction as a way to have a surrogate marker for your left ventricular and diastolic pressure at the bedside. You can use it to help you assess someone's volume status. So while we're going to focus on diastolic function and dysfunction and diagnosis today, we're going to use some of these points in 2 weeks when we go over advanced hemodynamics. And so having a baseline understanding that we're doing today is going to be helpful for 2 weeks from now. It's also going to be very helpful at the bedside. All right. So let's start with general diastolic dysfunction and kind of what happens and why it happens. So what we really want to focus on is how easily is blood able to go from the left atrium into the left ventricle. Okay, and that's really what we're assessing here. So there's a couple phases of diastole that we have to really understand before we even start talking about diastolic dysfunction. So there's a period of time during diastole when the left ventricle is starting to relax, but there's no change in the volume status within that ventricle. So the ventricle actually will start to untwist itself, start to decrease its pressure, and yet the mitral valve still remains closed. All right, and that's what we call our isovolemic relaxation time here. So what we can see on the left side of our screen is that we're looking here at our mitral inflow pattern. So this is the velocity of flow going past the mitral valve. But there's a period during diastole here in which there's no flow. And that's just because the ventricle is relaxing during that time, but the valve remains closed. All right. There becomes a point in which the left atrial pressure is high enough where it opens up that valve and flow starts. Okay. So early flow here, which is this we'll tell you later is called your E wave, okay, is dependent on the pressure gradient, so how high the pressure is in the left atrium. And if there's a high pressure in the left atrium and a low pressure in the left ventricle because it's starting to relax itself, what's going to happen is blood flow is going to go from a high pressure system into a low pressure system into the ventricle, right? And that's what our E wave is here. There becomes a period of time when the pressure between those two chambers starts to equilibrate or equalize. And that's this area here, okay? And this is called diastasis, in which there's minimal to no flow across the mitral valve because the two chambers have a similar size. And you can see here at the upper part of our screen, this is where the pressure starts to equilibrate between those two chambers. Late in diastole, we're going to see that the atrium contracts, right? And by the atrium contracting, it increases its pressure, and therefore is going to drive blood again across the mitral valve into the left ventricle, and that's where our A wave comes in. So early in diastasis, there's no flow. That's our isovolemic relaxation time. Then we have an E wave, which is the result of a pressure gradient between the atrium and the ventricle. There's a period of diastasis in which there's minimal flow. Then the atrium will contract, and you have your A wave, okay? So we're going to go over this a couple times, all right, and go through the stages of diastolic dysfunction. Now, what I want you to remember, and this is a very, very important point, is that in a normal, healthy person, you're able to very robustly relax your left ventricle. So it twists and kind of almost causes a sucking motion of blood into the ventricle. So in a young, healthy person, blood isn't just driven across the mitral valve because there's a higher pressure in the left atrium, but it's also kind of sucked in from that decreased pressure in the left ventricle due to a robust, quick untwisting of that ventricle that's very compliant. So that's why in young, healthy people, you may actually see a very high E wave here, higher than you would expect in a normal, healthy person. Does that make sense to everybody? All right, really important point. So diastolic dysfunction can be evaluated with a couple different ways, all right? That we're going to focus on many of them today. We're going to focus on our mitral inflow, our isovolemic relaxation time, and tissue Doppler with a little bit of a focus on pulmonary venous flow. And I didn't really focus on color flow propagation because we don't really use it clinically in the ICU. It's not tested very often in critical care boards. But just so you know what it is, basically, is that what we do is we have our apical four-chamber view, okay? And I'm just going to draw the left side right here. And what you want to do is you put color flow across the mitral valve. So you see the color flow coming here. And you put your M mode across this. And we talked about M mode across the mitral valve before. You'll see a little bit of an uptick as the valves go up. And then the second E wave, just like we spoke about a couple weeks ago in our mitral valve lecture. Basically, the slope of this E wave curve correlates with the stiffness of that ventricle. So if the ventricle is very stiff, you're going to see a more shallow slope than if you have a very compliant ventricle, which opens up, the valve opens up super easy across a low gradient, really compliant left ventricle. So you'll see a higher slope there using both a mix of color and M mode. But we're not going to talk about that. It's just so you know what it is if you read it in a textbook or anybody talks to you about it. So these are the general principal areas of how what we use to diagnose diastolic dysfunction or assess diastolic dysfunction. So up right here, we see our pressure gradients, which we're going to refer to a little bit. But for the most part, we talk about our transmitral flow here. We talk about our tissue Doppler and tissue velocity here. We talk a little bit about our pulmonary venous flow. And what we'll talk about in 2 weeks is our tricuspid regurgitation jet. But it's part of the algorithm here, so I included it a little bit. So we spoke a little bit already about the actual way that we assess diastolic dysfunction, but how do you do it at the bedside with the machine? So basically, you're going to get your apical four-chamber view in which we see our left ventricle, right, and our left atrium here, right, and this is our mitral valve. What you'll do is you'll take your pulse wave Doppler, okay, so not continuous wave, although you can help, continuous wave can help you at some points. You take a pulse wave Doppler and you put it distal to the mitral valve into the left ventricle, right? You want this gate area here, to be about 2 millimeters. You don't want it to be too big, but 2 millimeters is probably the best size. And you don't want to be too close to the mitral valve. When you're very close to the mitral valve, it's actually going to give you lower flows, and you're going to underestimate the actual flow velocity across that valve. So about 1 centimeter away from that mitral valve is probably the best location, all right? We spoke about it a little bit before, that you're going to have an area of your isovolemic relaxation time. You'll have an E wave, which happens because of the gradient between the left atrium and the left ventricle. We'll have a period of diastasis, in which there's no flow because the chambers have for the most part, equalized pressures. And then your atrium will contract, and you'll have a higher pressure in the left atrium, causing blood to go across the mitral valve. And that's the general flow in our mitral valve flow pattern. All right. So now we're going to go the grades of diastolic dysfunction, correlate with not only severity of disease, but in many cases mortality. So here in the first, we see normal diastolic function. We have a very quick upslope in our E wave with a little bit of a slow deceleration. So this is a period in which the chambers are starting to equilibrate here at our peak flow, and there's a slow return back down to normal. In grade 1 diastolic dysfunction, what happens is the left ventricle starts to have impaired relaxation, right? So it's a stiffer ventricle. And so, therefore, if the gradient in the left atrium stays pretty much the same, right? The left atrium has not reacted yet to anything. There's going to be less of a gradient between the left atrium and the left ventricle, right? Because you have a very stiff left ventricle and a relatively low pressure system in your left atrium. So the flow across your mitral valve in the early phase, right, which is dependent on both quick relaxation of the ventricle, but also the gradient between the two chambers, is going to be a low flow state. Does that make sense to everybody here? And so what happens is you have a higher volume within your left atrium. The left atrium still has a lot of blood in it. So when it contracts, you're going to see a high flow across the mitral valve. So you rely very heavily on your atrial kick in order to maintain your stroke volume in grade 1 diastolic dysfunction. So grade 1 diastolic dysfunction, if our normal wave looks like this, we're going to have a shorter E wave with a long deceleration time here. And then we're going to have a very high A wave because you have high pressure and high volume within the left atrium, and all that blood flow is going to go across the mitral valve when you contract. Later, what will happen is your left atrium, when it's seeing chronically high pressures with high volumes, it's going to hypertrophy. And you're also going to have increased left atrial pressure because of the amount of volume within that chamber over a period of time. And so that left atrium, that gradient between the left atrium and the left ventricle is restored. Now you have a higher left atrial pressure and a more robust, stronger left atrium. So you're going to have a lot of flow across this mitral valve early because your left atrium now has compensated and become stiff and strong itself. So your E wave returns back to what looks like a normal pattern, which used to be called pseudo-normal pattern. And then you'll still have high reliance on flow across the mitral valve with your atrial kick, as you can see by a higher flow in your E wave than you see in your A wave than you see from in normal diastolic dysfunction. Again, so a high E wave because you have a compensated left atrium. It decelerates very quickly because now the chamber is really stiff, and so once you hit equalization between the two chambers, blood flow just stops very quickly because you have a really thick, strong left ventricle. And then you still have an E wave, which is less for the most part than your A wave, which is less than your E wave, all right, but a little bit stronger and higher velocities than in normal function. So what do we see here? We see an E that's usually greater than an A, and we see a decreased deceleration time, which we'll talk about a little bit, and that's this time. Sorry, that's this time here. Right? That's the amount of time that it takes to go from peak back down to normal, okay? And that's your deceleration time. So because the chamber is very stiff, once you hit equalization, it just stops flow. And then we go on to grade 3 diastolic dysfunction, in which you have a very high left atrial pressure, very high stiff left atrium, very high stiff left ventricle. And so the blood flow is very, very brisk and short-lived across the mitral valve as the two chambers hit equalization very quickly. And then you have a short deceleration time here again, and you have a high E wave and a small A wave because you have less, that atrium as it contracts isn't able to expel blood across the mitral valve because that left ventricle is so stiff. All right. Now, what's the difference between grade 3 and grade 4 diastolic dysfunction? Grade 4 diastolic dysfunction is non-reversible. So if I took a patient with grade 3 diastolic dysfunction and I asked them to do a Valsalva maneuver, right? So they bear down, right, against a closed glottis, and they increase their intrathoracic pressure by about 20 to 40 millimeters of mercury. What's going to happen is you're going to have decreased preload, right? Because you're have increased intrathoracic pressure. Your IVC is not going to fill all the way into your atrium, and your preload is going to go down. So what we see in that case is that people who have grade 3 diastolic dysfunction will convert to look like grade 2 diastolic dysfunction by that maneuver because you're decreasing volume and therefore decreasing left atrial pressure, right? But in grade 4 diastolic dysfunction, it's fixed. So that person is not reversible with Valsalva maneuver. All right. So
So on a lot of the echoes you see grade 1. Is that any time, it will say mild, is that really any time the E has a small amplitude in the A wave?
We're going to go over the algorithm for that.
Okay.
Yep. All right. So we spoke a little bit about isovolemic relaxation time here, right? Before. So that's the period before, in the beginning of diastole, before the mitral valve opens and there's flow across the mitral valve, right? That's our isovolemic relaxation time. How do we obtain what that time is? So basically, you're going to go to your apical 5-chamber view. So we take our apical 4-chamber, and then we fan our probe down towards the body a little bit more. So we look more anteriorly, and we pick up our aortic outflow tract. We're going to put our pulse wave Doppler gate right at the opening of the aortic outflow tract and make the gate a little bit bigger than we normally would. So we catch a lot of flow both across the mitral valve, right, and across the aortic outflow tract. So here what we see is this is the flow across our aortic outflow tract, so flow going away from the probe. And then here we see flow that's coming across the mitral valve. So we're picking up both parts of systole and diastole here, all right? And the period between the stoppage of flow across the aortic valve and the beginning of flow across the mitral valve is our isovolemic relaxation time, all right? So this depends on the rate of relaxation, right? So in grade 1 diastolic dysfunction, this is going to be longer. And as we get stiffer and stiffer in our left ventricle, now our isovolemic relaxation time will actually start to get smaller and smaller, right? So that's one of the things that I always had a difficulty when I was learning diastology, was this isovolemic relaxation time. And it really just corresponds with the development of stiffness across the ventricle. So in early diastolic dysfunction, so grade 1 diastolic dysfunction, you're going to see a longer isovolemic relaxation time, right? Because the ventricle is taking a long time to slowly release, but does eventually release and allow filling. Where when it's very stiff, right, and you have a high left atrial pressure, it doesn't take a lot of untwisting for the left atrial pressure to be high enough to send blood flow across the valve. And so that's why it gets shorter and shorter, because your left atrial pressure is getting higher and higher as you go along with your chronic diastolic dysfunction. So one of the things that we want to remember is that it's very non-specific. Okay, so it will increase with age. It depends on your heart rate. It depends on your systolic function. So someone who has a high heart rate, their isovolemic relaxation time may be adjusted compared to somebody who has a low heart rate. So not a perfect component, but we can use it in our diagnosis. All right. So what do we see here? We see normal with a normal isovolemic relaxation time. And as we see in grade 1 diastolic dysfunction, we start to see a prolonged isovolemic relaxation time because it takes a long time for us to get a high enough pressure in that left atrium to open up the valve. And then as we have as our left atrial pressure goes up due to chronic diastolic dysfunction, it doesn't take a lot for the pressure to increase enough to open the valve. So we start to see a shorter isovolemic relaxation time in grade 2, and then subsequently in grade 3 and grade 4, that isovolemic relaxation time gets smaller and smaller. Okay? All right. So let's move on to tissue Doppler. So tissue Doppler is a function of the machine. Okay? So normally in pulse wave Doppler or continuous wave Doppler, it is looking for high frequency, low amplitude velocity. So it's looking for things that are moving very quickly across the valve. But by adjusting and placing on tissue Doppler settings, it's going to try to isolate out the lower frequency and the higher amplitude waves. So tissue that moves slower. So if we're looking at the movement of blood across a valve, it's going to be moving really quickly. So we want to use normal pulse wave Doppler. If we're looking at how fast tissue is moving, then we want to use tissue Doppler, which is going to give us a lower frequency, higher amplitude signal that we're looking for. All right, so it's just it's selecting out which tissue that we want to find. So basically here, if I can go back to this, we want to be taking a look at this area here and this area here. And we're just trying to see how is that tissue itself moving. So this is something called our S wave. So as tissue is moving towards the probe, right? So this is a positive deflection above here, positive. That means that this tissue is moving upwards towards the probe, all right? So in systole, we're going to see the tissue moving upwards, contracting, and then relaxing back to its normal state. So this is your S wave, which stands for or S prime in tissue Doppler, stands for our systolic function, okay? And here, as the tissue relaxes in diastole, so the mitral valve annulus starts to relax and go this way, downwards, away from the probe, we see a negative deflection. So you'll see it corresponds very nicely in an E and an A wave pattern. Because we're using tissue Doppler, we give it the signal of E primed and A primed to differentiate it from normal pulse wave Doppler. So early, right? We have an early filling in which the tissue is moving away from the probe. Okay, as blood is relaxed, as blood is moving into the ventricle. We have a period in which there's no movement of the tissue. And again, once again, another downward deflection as the tissue moves away from the probe, where that chamber opens up a little bit more as blood flow is going into it. So it looks very similar to our E and our A wave flow, okay? And what's very nice is that tissue Doppler is dependent on the intrinsic diastolic function of the tissue. where our mitral valve flow is not only dependent on how stiff the tissue is, but also your preload. So if you have higher preload, you're going to have higher flow and higher velocity across the mitral valve. Where in patients who have diastolic dysfunction, that tissue is going to move relatively consistently. Now, we spoke earlier about young healthy patients. Because young healthy patients are able to have an active untwisting and relaxation of the ventricle, so it's more of an active process, they can actually have their tissue Doppler increase as well with higher preloads. Or if they're exercising or say they went out for a run and then you just check their tissue Doppler right after, you're going to see more exaggerated tissue Doppler velocities as well. So this is why diastolic dysfunction and using your E waves and your E primed waves in a young healthy person is less reliable because there's an active component. And we'll go over to E primed later. So this is an example of how we do our tissue Doppler. So we see here that we set our gate up at the mitral valve annulus, right? So at the tissue right next to the mitral valve. And we see an S wave here and two waves, our E primed wave and our A primed wave here. And we measure the maximum velocity, which here is about 5 centimeters per second. All right. Now, if I were to ask you which mitral valve annulus, this is a bad image. So let's say we're checking tissue Doppler here or here. So this is our lateral wall and this is our medial wall. Which of these walls do you think is going to have a higher velocity? The lateral wall or the medial wall? Or do you think they'll be the same? You think the lateral wall will have a higher velocity, and why is that?
There's, on the medial wall, you have frictions with the other side.
So yes, there's restrictions, and it's because of something called the interventricular fibrosa. So there's a tissue within the in the septum that is going to tether the mitral valve annulus more than the lateral wall. Now we'll talk about it in later lectures, but patients who have things like restrictive cardiomyopathy or pericarditis, they may have actual lateral wall changes compared to their medial wall changes. But normally your lateral wall velocity will be greater than your medial wall velocity because of your interventricular fibrosa. Okay, so that's something that will be tested for you. And you'll notice in the criteria that you have different criteria for your lateral and your medial wall. All right, so this is putting a couple things together with our tissue Doppler. So here we see grade 1 diastolic dysfunction, a low E wave, a high A wave, and a relatively normal E primed wave, right? But it's a little bit reduced, but not major reduced, okay? In our grade 2 diastolic dysfunction, which some people used to call pseudonormal, which looks very similar to our normal up top here, we see that what can differentiate between a patient who has normal diastolic dysfunction and grade 2 or pseudonormal diastolic dysfunction is that the E wave is actually reduced compared to normal. And we'll go over what the criteria are for that. So if you have someone who has what looks like a normal E to A mitral valve inflow, but their E prime wave is decreased, then that is more going to put them in the grade 2 diastolic dysfunction versus normal diastolic dysfunction. Does that make sense? So it's a way that you can differentiate that pseudonormal pattern. And we can see as someone increases to grade 3 diastolic dysfunction, you have severe decreases in your E primed wave. So the tissue itself is super stiff. So the tissue is not able to move a lot. So you're going to have low tissue Doppler velocity. Okay. All right. So this is putting a lot of these together. We're going to move forward very shortly into our pulmonary vein flow. But we have someone who has normal flow here, right? And we have an E that's greater than A and a preserved E primed wave. Where someone who has grade 1 diastolic dysfunction or impaired relaxation, we see that there's a low pressure gradient between the atrium and the ventricle, so our E wave is going to be smaller, right? And our E primed wave is a little bit less than prior, but it's relatively close to normal. We move into our grade 2 diastolic dysfunction, which is here, or our pseudonormal pattern, in which the E and A mitral inflow look very similar to our normal flow. But now we look at our tissue Doppler and we notice that there's actually low flow of the actual, or low movement of the tissue itself, so that's more consistent with grade 2 diastolic dysfunction. So if I'm making a test and I'm trying to see, do people truly understand diastolic dysfunction, wouldn't I focus on this pseudonormal pattern, right? That would, grade 1 diastolic dysfunction, obvious, right? Grade 3 and grade 4 diastolic dysfunction in a non-healthy person, right? Not your 18-year-old athlete, right? Is going to look much different than normal. And so I would focus a lot on the pseudonormal pattern. And that's where a lot of the criteria for diagnoses will come in. All right. So this is just an example of our tissue Doppler. Again, our S primed wave, our S wave, our E primed wave, and our A primed wave. All right. Now, pulmonic vein flow. I will be very honest with you in saying that this is not used very often in critical care medicine. Okay. In the echo lab, this is only the pulmonic, pulmonary veins are usually only visualized anywhere from 60 to 80% of the time. And that's in normal, non-critically ill patients in the lab. So in the ICU, getting this view is going to be a little bit harder. And so it's not used very often in clinical practice. I'll admit, I very rarely use it. However, it is something that you're going to read in your textbooks, and it is part of some of the criteria. And so that's why I think it's very important that, here we don't want to just pass the echo boards. We want to be experts in the field, right? And so that's why I want you to know this flow pattern. So flow, basically you want to get your apical 4-chamber view. And again, tilt the base of your probe downward towards the body to look more anteriorly. And then just below the left atrium, you're going to see inflow of your right and your left pulmonary veins. About 5 millimeters away from where the vein enters the atrium, you're going to want to set your pulse wave or continuous wave Doppler to catch the flow. And over here, this is what the flow actually looks like. All right. So S is systole, D is diastole, and AR is your atrial reversal. Good. So basically, in systole, your mitral valve annulus is going to move upwards here. Okay. So it's going to pull the tissue upwards, and therefore you're going to have some decreased pressure in your left atrium, right? So it's going to then pull blood from your pulmonic veins into your left atrium, and therefore you're going to have a positive deflection here. Does that make sense for everybody? In diastole, where the pressure is low in the left atrium as it's filling, again, you're going to have a second filling pattern into your left atrium from your pulmonic veins. And as your atrium contracts, you're going to send blood back up into the left ventricle, but some of that blood is going to go backwards into your pulmonic veins, and that's why you have this negative deflection, all right? In young, healthy patients, you have a very high D wave, okay? And as you get older in age, your systolic to diastolic ratio is actually going to decline. Okay, so those are just key points to keep in mind. But I want you to know what the flow pattern looks like and why it looks like that. So early in systole, your mitral valve annulus moves upwards towards the apex. It's going to pull blood from the vein into the left atrium. In diastole, again, the pressure in the left atrium is low, so you're going to have filling from your veins into your atrium. And then lastly, as your atrium contracts, it's going to send blood forward into your left ventricle, but also retrograde into your pulmonic veins. And that's where you get this AR signal. All right. So here are examples of what happens with your pulmonic vein flow during progression of diastolic dysfunction. So early in diastolic dysfunction, you start to see decrease in your flow during your D wave. And that's primarily because now you have a higher pressure in your left atrium. And so there's going to be less flow that's going from the vein into the atrium. However, as we progress in our diastolic dysfunction, we start to see that the systolic motion of the ventricle is probably a little bit less, and you're not going to be sucking blood into your left atrium because the pressure in the left atrium is progressively getting higher and higher and higher, right? And that's what makes us have that pseudonormal pattern, right? That your left atrium gets a higher pressure, and therefore your E wave starts to look normal again. So as the pressure in your left atrium increases, it's going to cause you to have decreasing flow during systole, right, in your pulmonic vein. But most importantly, and the key point to your pulmonic vein flow is your AR signal, right? As you have a big stiff ventricle and your left atrial pressure gets higher, and now you're compressing against a very stiff ventricle, all that blood is not going to go forward to your ventricle, some of the blood flow is going to go back into your pulmonic vein because you have such a high pressure in your ventricle that it can't expel all the blood forward. But your left atrial pressure is high enough where it's compressing really hard, and so it's going to go through the path of least resistance, which is retrograde back into that vein, right? So if we look at so these are our veins, this is our left ventricle, this is our left atrium. As we progress and have a very thick left ventricle, right, and a very strong high pressure left atrium, it's going to try to push blood forward, and some blood is going to go forward. However, we're going to notice that the pressure in your veins is less, and so a lot of the flow is going to go retrograde here, and so we have a higher and longer AR signal. Okay? Again, not used very often, but is in a lot of the textbooks that you're going to read, so I want you to understand and just simplify the physiology. So in 2016, the American Society of Echocardiography revamped their diagnostic criteria for diastolic dysfunction, right? And so now they separate between normal left ventricular ejection fraction and impaired left ventricular ejection fraction. So this is what we talked about a little bit, that this is the criteria. So it's interesting that in left ventricular normal LV function, your mitral valve inflow pattern, which is the main thing that we think about with diastolic dysfunction, right? Those E and those A waves aren't included in the criteria, right? They were prior to 2016. So if you have someone who has a high E to E prime ratio, right, or a very low E prime ratio, then those are going to be patients that are most consistent with having diastolic dysfunction in the setting of a normal EF. So why, again, does the E to E prime matter, right? And we're going to focus on this a little bit. It's because we're taking a look at the flow through the valve, comparing it to the movement of the tissue, okay? The flow through the valve is your E wave, right? And that's dependent on diastolic function, but also your preload, okay? Where in patients who had diastolic dysfunction, your E prime wave is only dependent on the actual diastolic function of the tissue and is not preload dependent, it's preload independent. Again, only in patients with diastolic dysfunction. So if you have a high E to E prime ratio, what does that tell me? That tells me that you have high preload, high filling pressures, right? So an E to E prime, for that reason, in patients who have diastolic dysfunction, can be used as a surrogate to estimate increased left ventricular and diastolic pressure, okay? And so we're going to go over that in a little bit. But so basically this is, and you guys will have this lecture, and so you can look at these, and these are very readily available on the internet to look at the criteria. But now we look at the criteria, which is a little bit more complex for patients who have decreased left ventricular ejection fraction, right? And so basically you're going to take a look at your E to A ratio. If your E to A ratio is less than 0.8, okay, and your E wave is less than 50 centimeters per second. So you have a low E wave, and you have an E wave that's usually less than your A wave in velocity. That's going to be most consistent with grade 1 diastolic dysfunction. But what happens if you have an E to A ratio which is less than 0.8, but your E wave is still pretty robust? Well, then you go down into your other criteria, and we look at our E to E prime, our tricuspid regurgitation velocity, and our left atrial volume. Now, I don't calculate left atrial volume at the bedside, but you can do that, and you can do it in a very similar way that you look at volume within the left ventricle during systolic function that was talked about last week. So again, we're not going to go over this in general, just for the sake of time, but this is readily available on the internet, and so before you take your boards, I encourage you to take a look at this, and we're going to go over a couple in our questions. Now, there are a couple points that are really important to remember, and those are times when normal diastolic function assessment is not as reliable. And so in the setting of tachycardia, right, that period of diastole in which the two chambers, the left atrium and the left ventricle, are equal is substantially less. And at high enough heart rates, your E and A wave will actually fuse. And so that gives you a really hard time at figuring out what's the ratio between your E to A. So in the setting of tachycardia, you can't really use your deceleration time, and your E to A are fused. So the one thing that you can use to assess for diastolic dysfunction is your E to E prime ratio. So the peak of that fused wave will most likely be your E wave, and you can use that as a calculation of your E to E prime. In the setting of atrial fibrillation, you will not have an A wave. You have a lot of beat-to-beat variability. We see that all the time in our cardiac output assessment, which we'll go over later. And so we actually can use two other areas. Your E to E prime, we actually use a cutoff of 11. So an E to E prime of 11 or higher in patients with AFib will be consistent with increased left ventricular and diastolic pressure, or increased filling pressures, and subsequent diastolic dysfunction. You can also use your deceleration time, and the deceleration time of your E wave less than 160 milliseconds will be consistent with diastolic dysfunction. Just so everybody knows, normal is around 220. In the setting of mitral stenosis, our E to A is not really helpful, right? Because that valve doesn't open just based on gradients alone. It's also structurally limited in being able to open, and the flow across that valve subsequently will be altered as well. So our E to A is going to be relatively useless. Our E to E prime will also be less reliable because our E flow is going to be altered dramatically. So a couple ways that we can assess for diastolic dysfunction in mitral stenosis is a very short isovolemic relaxation time, which we talked about earlier. If our E wave is very highly increased, like in grade 3 diastolic dysfunction, that may be a hint that there's diastolic dysfunction, and will be associated with higher filling pressures as well. And then in the setting of hypertrophic cardiomyopathy, again, our E to A wave is going to be altered because we're going to be altering flow across the mitral valve. And again, our E to E prime is less reliable, although can be helpful. This is an area where pulmonary venous flow can actually be very helpful in diagnosing diastolic dysfunction. And if you have a very prolonged AR, so atrial reversal or atrial flow reversal, that's going to be most consistent with progression to diastolic dysfunction. So these are the areas where you have to be very careful in using what we talked about already. All right, there's a really great Migos song in here, but maybe the people at home heard it better. All right. So let's go over some questions to hammer this home. So comorbidities that do not typically confound assessment of diastolic dysfunction include, so tachycardia, AFib, or recent Mays procedure or pulmonary vein isolation. So hypertension, aortic stenosis, or pulmonary hypertension. Severe mitral calcification, stenosis, or recent mitral valve surgery. Significant aortic or mitral regurg, or ventricular pacing, LVADs, cardiac transplantations. Which of these patient populations would you be able to use diastolic dysfunction? Or should we just go through all of them and say yes or no? So you think it's B? Okay. So tachycardia, AFib, recent Mays. So recent Mays, you don't have that A wave, and so that's why this isn't good. We talked about AFib and tachycardia. Pulmonary vein isolation is very similar to Mays procedure. Mitral valve calcification, again, stenosis, we spoke about that. Regurg, we didn't speak about it as much, but if you have very high severe regurgitation, it's going to affect your flow across that valve, given change in volumes. And then when you have ventricular pacing, you're not going to have that atrial kick component, right? And so this isn't going to be helpful. So you are correct. All right, this is an example of E to A wave fusion here in the setting of tachycardia. So which of the following statements are true about pulmonary venous flow pattern? So peak AR greater than 35 centimeters per second suggests increased LV-EDP. Pulmonary vein S wave is related to LV relaxation. The S to D ratio is an accurate estimation of LV pressures in patients with preserved or reduced systolic function. Pulmonary venous AR duration less than mitral valve A duration indicates increased LV-EDP, and pulmonary venous AR can be obtained in only 50% of patients. So these are pretty complex questions, right? But I think you can all answer them. So let's start with it. Peak AR greater than 35 centimeters per second suggests elevated LV-EDP. So what happens as we have worsening diastolic dysfunction and worsening preload? What happens to our pulmonary venous flow pattern? So normally it looks like this, right? So SDAR. And what happens as we progress in disease and progress in increased pressures?
I'm pretty sure it reverses, but I don't think that AR ends up changing.
Okay.
It does? Okay. I don't know.
So the area under the curve will increase.
Yes, but the peak, I'm saying, I don't think it changes.
So the peak and the duration will both increase.
Okay.
Yeah. So
Okay.
so this will get longer. So So pulmonary S wave is related to relaxation. Yes or no? What's that?
No.
No. Why is that? Which wave is related to relaxation? What's that?
To healthy relaxation.
Good. This is the D wave is the correct answer here. The S to D ratio provides an accurate estimation of LV filling pressures in patients with preserved and reduced systolic function.
Reduced or preserved.
Good. So only one of these, right? So not preserved. All right. Pulmonary venous AR duration is less than mitral valve A duration indicates increased LV EDP.
Should be less.
So normal is less, right? So normally we want this AR to be less than our A, right? And so this is just wrong. So if your AR duration is greater than your inflow, if your AR is greater than your A wave, that will be consistent with increased LV EDP. Pulmonary venous flow AR can be obtained in 50% of patients.
70 to 80.
Right? Yeah. So we said
60.
so 60 to 80, depending on the literature you look at, and that's in the lab itself. So not really relatable to us at the bedside. Right? So we spoke a little bit about our AR pattern. So as we progress in our filling pressures and our diastolic dysfunction, our AR gets a higher velocity and it also starts to lengthen out as well, right? And you can see here our A wave keeps getting smaller, right? And our AR wave keeps getting bigger, right? And so an AR greater than A is worrisome for increased filling pressures. Again, I drive the pulmonary venous flow home during these lectures because if you go to learn it on your own, it can be very confusing and you can get really frustrated with it. But just simplify it. Why does it fill positively in systole? It's because the annulus is going up and you're having you have more volume that could fill into your atrium. And then in diastole, as all the tissues are relaxing, again, there's going to be more flow from the vein into the atrium. And as the atrium contracts, blood flow is going to go antegrade into the ventricle and retrograde into the vein, so you're going to have a negative deflection. If you have a really stiff ventricle, that atrium, even if it's really strong, is not going to be able to push a lot of flow across the mitral valve, and a lot's going to go retrograde. It's going to cause almost like a pulmonic vein regurgitation. All right. In patients with AFib, LV filling pressures could be estimated with which of the following statements? E to E prime greater than 11, a short deceleration time in patients with normal ejection fraction, higher left atrial size, peak velocity of diastolic pulmonary venous flow will reflect atrial pressure, and it's impossible to estimate pulmonary capillary wedge pressure or LVEDP since there's no A wave, and the variability of the cycle length precludes any accurate estimation.
A is incorrect.
A is incorrect?
E should be 14 and up. So
Say that one more time.
the E to E prime should be like greater than 14.
Okay.
That's incorrect.
So why don't we stop there? So in what Yanika is talking about, she's getting a little bit ahead of herself because she's incredibly advanced as a person and as a clinician, right? So our E to we talked about our E to E prime, right? And its relation of the mitral valve inflow to the tissue Doppler flow, right? So as our E to E prime increases, right, it means that our E wave velocity is going up, right, which is dependent on diastolic function, right, stiffness of the ventricle, and also preload. So if this is going up and our E prime wave, which stays relatively constant, as we talked about in patients with diastolic dysfunction, that's going to mean that our preload and diastolic dysfunction over something that's just related to diastolic dysfunction leaves us with just preload. So a high E to E prime is going to be most consistent with someone with increased filling pressures, increased LVEDP. And so we're going to talk about this in 2 weeks, but the numbers that you worry about are 15 and 8, okay? So if you're less than 8, that means your filling pressures are probably low to normal. If you're greater than 15, that means your filling pressures are high or increased with a pulmonary capillary wedge pressure greater than 18. But in between 8 and 15 is indeterminate, meaning I don't know what that means. So E to E primed of 9 compared to an E to E prime of 11 doesn't mean anything to me in a patient with normal sinus rhythm. But what we talked about in one of our slides prior is in AFib in particular, what's our cutoff for our E to E prime? 11, right? So that's why this answer is correct. But in other patients, like Yanika is saying, we use the cutoff of around 15. Does that make sense? So this is where knowing the specifics for AFib is very helpful. Okay, but you're right. In all other patients, we use the cutoff of 15. All right. So that's basically the main answer, and that's what they're trying to get you to go towards. So one of the things I want you to remember is a large size, a big size of an atrium doesn't mean big pressure, right? Just because you have a big left ventricle, a big dilated ventricle and dilated cardiomyopathy, it doesn't mean that the pressure is high in that ventricle. It just means that over a period of time, it's dilated out. So you can have a low pressure system with a dilated ventricle if someone's had chronic disease. So atrial size does not reflect chronic pressures. So this is what we talked about here, that in AFib, we use the E to E prime of 11. Does everybody understand why we use E to E prime and the idea between comparing the mitral valve inflow and the tissue Doppler? Does that make sense for everybody here? We're going to talk about that a lot in 2 weeks when we do our advanced hemodynamics assessment. 61-year-old male with a history of hypertension, complains of exercise intolerance, PFTs are normal, heart rate at rest is around 60, he's a normal EF, he has a little bit of hypertrophy, no valvular issues, and this is the Doppler data. So the cause of the symptoms are unlikely cardiac. Consider coronary angiogram. We conclude that the patient has elevated filling pressures and should be given a diuretic. Consider diastolic stress testing, and BNP is 500. What do you guys think?
So
let's look. So he has an E to A is what?
it's less than 1. It's less than actually 0.8 actually.
So it's
0.8.
It's exactly 0.8,
Yeah.
right? Perfect. All right. Our E primed is 8, right? Our tricuspid regurgitation jet is less than 2.7, right? So pretty normal. And our E to E prime, which you could have done by putting 48 divided by 8 is equal to 6, okay? So this is actually an interesting question because the answer is technically considered diagnostic stress testing, right? And I'll explain to you why. So this is our algorithm for looking at a patient with diastolic dysfunction with decreased left ventricular ejection fraction. This question was done before they made the updates in 2016. And so therefore it's using the older mitral valve inflow pattern where it's using your E to A, right? So it's plugging it into this algorithm, all right? So this is a patient who has technically indeterminate left ventricular, indeterminate diastolic dysfunction. It looks like it's probably grade 1 diastolic dysfunction. Your E to A is here. Your E wave is less than 50, right? So you kind of fall into this grade 1 diastolic dysfunction pattern here. And so for a patient who has symptoms with diastolic dysfunction, very often what they would do is they have them undergo stress testing and then recheck these values to see is the diastolic dysfunction actually what's causing that patient to have exertional symptoms. So if you start to increase their preload by increasing their cardiac output, right? So you have them get on a treadmill or give them medications to increase their cardiac output, you're going to see their preload go up, right? And you're going to see progression of their diastolic dysfunction go forward. And that's the idea from an outpatient standpoint. But I like this question because it allows you to work through the numbers, right, to assess someone's diastolic dysfunction. So we have an E to A, which is around 0.8, right? Our E to E primed, right, is pretty low, right? It's less than 6. So while this patient has evidence of diastolic dysfunction, this patient does not have increased filling pressures, right? I'm going through these questions pretty quickly just so for the sake of time, we can get in under an hour. Which statement is most correct with respect to application of Valsalva maneuver in assessment of diastolic function? So lack of reversibility of E to A with Valsalva in patients with advanced diastolic function indicates irreversible restrictive physiology and poor prognosis. Valsalva maneuver is a sensitive and specific way to differentiate normal from stage 1 diastolic dysfunction. Valsalva maneuver should be used in every patient. In cardiac patients or heart failure patients with a decreased E to A ratio is highly specific for increased LV filling pressures.
You said it.
So, good. So the answer is not A. The answer is technically D. Yeah. So it's a power move. I want to sound really smart. So the reason why this is important is Valsalva maneuver requires significant drop in your pressures in order to show changes. So it's very patient dependent. So if a patient's not able to drop their pressures by 20 to 40 millimeters of mercury by doing a Valsalva, then this is not going to be reliable. So you can have a patient who you think has what looks like maybe pseudo-normal, and you want to see are they going to reverse back to grade 1 diastolic dysfunction, right, by decreasing their preload. If they're trying to do a Valsalva but they're not reaching the appropriate thresholds, it's not going to be a reliable test. And so this question gets you to understand, number one, that the Valsalva will decrease preload and may cause you to go in the other direction of diastolic dysfunction, so grade 3 to grade 2 or grade 2 to grade 1 because you're dropping preload. But it is not a perfect test, right? And it's very patient dependent, so shouldn't be used in every patient. Okay, so for a patient who has decreased left systolic function and your E to A, right, decreases significantly, those patients are most often have grade 3 diastolic dysfunction. So that's another little pearl, is that if you have decreased systolic function, right, and you have a high E wave, that probably is grade 3 diastolic dysfunction and not normal. Does that make sense? So if you have LV systolic function and what looks like likely advanced diastolic dysfunction, that you probably have advanced diastolic dysfunction. It's hard to have systolic dysfunction for a prolonged period of time isolated from diastolic dysfunction. So it kind of hits on a couple major points. So not a great question, but.
So, but why is D?
What's that?
So can you explain D and a decrease of greater than 50% in A-to-A ratio? Oh, so like if there's a reversal.
So if this patient has grade 3 diastolic dysfunction, right, and they are able to reverse a little bit, even though it doesn't go all the way back, and this comes down to here,
Yeah. And
that patient
greater than 50%, is that like what they do in the labs, like?
To be perfectly honest with you, I don't know of the study that they're referring to in this. There's not a specific study that the question bank has hinted on, but basically, what it's saying is if you have decreased systolic function and you have a high E to A ratio and you do a Valsalva and this goes down a significant amount, it shows you that worsening diastolic dysfunction is related to higher filling pressures as well.
So Valsalva is only useful if there is like a positive change. If you don't see any changes, you can't really conclude it.
Unless you're like, let's say you're doing like you have an esophageal probe in and you see a significant drop. That's the only way that you could really 100%. So a positive change in the setting of decreased systolic function is consistent with higher filling pressures, but Valsalva itself is a very limited technique.
Got it.
But when are you seeing that? Like when they ask that 50% change, when are you seeing that 50%?
When they Valsalva. So if you have someone Valsalva, they drop their preload, your E wave is going to go down significantly, right?
So you are using the Valsalva
In that patient population. But if it didn't go down, that's not you don't know, and you don't know how reliable their Valsalva maneuver is. We see people do it all the time. It looks like they're doing a Valsalva, but you don't like.
Specific, but not.
I barely did it.
Thank you.
So this is one of my I think this is one of my favorite questions. So figure 31 represents 3 different pulse wave Doppler recordings of mitral inflow velocity of a 63-year-old man diagnosed with cardiac amyloid. The Doppler recordings are acquired at different stages of his disease. AFib is a common issue with these patients. At what stage of the disease would a sudden onset of atrial fibrillation most likely cause a marked increase in symptoms?
I think the first figure.
This one?
Yeah.
Why do we think A? Talk me through it.
He's very, very reliant on his atrial kick.
Good. Yes, that's exactly the reasoning here. So in patients who have early diastolic dysfunction, they develop rapid AFib and they have immediate drop in their hemodynamics. now we understand why that is. So these are patients who very often need either chemical or electrical cardioversion because they do not tolerate atrial fibrillation because they're not able to maintain their stroke volumes, right? So at the bedside, this is the stuff that's really, really important. And later, I'm going to tell you about a case that I had actually this week in Spear Malka Hill that really brought this to light. So based on this figure here, what could you say about the underlying diastolic function of this patient?
Okay.
So transmitral gradient suddenly increases in mid-diastole because of decreased LV compliance. This type of inflow pattern is sometimes seen in young individuals and can be explained by vigorous LV relaxation. This finding represents a very early stage of diastolic dysfunction. This patient has marked delayed relaxation. Preload reduction will reveal grade 1 diastolic dysfunction. And the Doppler tracing is suggestive of atrial mechanical dysfunction, possibly due to recent episodes of atrial tachycardia. So does this look like, what kind of diastolic dysfunction do you think this is? Grade normal, grade 1, grade 2, grade 3, grade 2, also known as pseudonormalization. Why do you say that?
Because it looks like a normal pattern.
Yeah, but so why would it be normal?
Looks normal, but it appears delayed.
So what we see here is that there's a shorter isovolemic relaxation time, but that's just by gross visualization. Your deceleration time here, which is highlighted, right, is very rapid, right? So that would be more consistent with pseudonormal versus normal, right? But what's really interesting is what the heck is this wave here? Right? So I have an E wave, I got this random wave, and I have an A wave, right? Yeah, so this is called your L wave. So this is in mid-diastole during diastasis. There's a high enough pressure in that left atrium, right, that there continues to be blood flow across the mitral valve when these two chambers should have equilibrated, right? So this, in patients who have diastolic dysfunction, is related to high filling pressures. So this is another example of high filling pressures with patients with no diastolic dysfunction. So we take this another step. So the answer here is D. Now, why would preload reduction reveal stage 1 diastolic dysfunction? So we said we're grade 2. And what is preload reduction? It's a Valsalva maneuver, right? Either with diuresis or Valsalva. And then what happens when you have someone with increased pressures and progressive diastolic dysfunction? What do you often see is you go backwards in diastolic dysfunction. So you go from a grade 2 to a grade 3 to a grade 2, or grade 2 to a grade 1. And so that's what this is showing you. So this is showing us that we have evidence of grade 2 diastolic dysfunction, so pseudonormal, as noted by what looks like a normal E to A ratio, but a rapid deceleration time, right? So blood flow went into the mitral valve, past the mitral valve into the left ventricle, which is stiff. Once it hit equilibration, flow stops really quickly. So that we have a really quick deceleration time in our flow pattern. And we also see this other atypical wave called our L wave, which is consistent with high pressures, which is allowing blood flow to continuously go across the mitral valve when it shouldn't anymore because your left atrial pressure is so high. And then what the question is asking us is, if you decrease preload, right, you're going to go backwards in your diastology to a grade 1 diastolic dysfunction. Cool. So you'll see clinically at the bedside someone who you think is volume overloaded. You have a grade 3 diastolic pattern. You diurese them aggressively over a couple of days, and now they look like a grade 2 diastolic dysfunction. And you're like, oh, interesting. They were having higher filling pressures. All right. Now, it's not the exact same mechanism, but you remember in our M mode talk that we talked about that B bump, right? The little bump up of the mitral valve when you have high LV EDP. So I try to think of it as the same way. Well, it's not related to the same. It's just when that mitral valve should be closed, it pops back open again because of high left atrial pressures. Right, so think about them very related. We're almost done. A couple questions. 61-year-old with ischemic cardiomyopathy is referred for cardiac resynchronization. Just before implantation of her BiV device, she undergoes transthoracic echo. 6 months later, a new echo is obtained. Based on LV Doppler filling pattern, which is correct? So our E to A got worse, right? Anybody else? LV, you think the pressures have decreased?
No.
No.
LP stiffness.
Good. All right. So we see our E to A ratio, 111 over 28, is greater than 3. When I see this ratio this high in a person who has known cardiomyopathy, right, not a normal, healthy young person who's having vigorous activity, right, then I think that they probably have grade 3 diastolic dysfunction, right? So this patient is having worsening of their diastolic dysfunction as their E to A is progressively going up. We're also seeing our deceleration time is going down, right? And so these are findings that our LV stiffness is worsening. So here, what do we see? We see our tissue Doppler, right? And here we see our S primed wave, right? We see an E primed, and we see our A primed here, right? We see that the velocity of our E primed wave is also going down later, right? So that's showing us that the muscle itself is getting stiffer and not moving as well as before. And our E to E primed, right, ratio, so 111 over 0.3 versus 72 divided by 0.04, right, or 4, is consistent with higher filling pressures as well. So we're getting a stiffer ventricle, higher pressures. All right, this might be one of our last questions. I think we have two. I think we have two more. What's that? No, you have to be really smart with math. Yeah, it's like any other standardized test rate calculator. So 48-year-old, previously healthy male, he's a lobbyist, recently started noticing increased shortness of breath while walking up the U.S. Capitol steps to the lobby for healthcare reform over the past 4 weeks. Very in-depth question. No history of previous cardiovascular disease. ECG shows sinus tachycardia without evidence of Q wave or ST alteration. So it looks like a normal EKG. Physical exam remarkable for decreased blood pressure, high heart rate, relatively increased weight or higher weight. Cardiovascular examination just demonstrates laterally placed LV apical impulse and an inaudible S3 on auscultation. Pulmonary examination is notable for faint bilateral crackles at the bases, traced by pedal edema. BNP is elevated. TTE here. That's that's not that good, right? Unhealthy. Baseline diastolic assessment is shown in these figures here. What can you conclude about LV compliance?
Yeah, I think decreased.
You think?
I say that based off the increased E to A ratio, S over D seems low. The AR looks relatively large. So I think LV compliance is decreased.
Great. And our E to E primed is probably pretty high, right? See how low we're right around 8. So you're right. You're 100% correct. You took all of the principles of diastology and you put it together in this one question. So this is, we talked about it earlier, and I plan to talk about it at this point, but in our E to E primed, we want to focus on two major points. Our 8 and 15 are the numbers that we have. So comparing the mitral valve inflow velocity, which is E, to our tissue Doppler velocity, which is E primed, right? If that number is less than 8, then our LV EDP is less than 18. If our ED prime is greater than 15, our LV EDP is greater than 15, right? In most patients. And that's how you want to use it. In between 8 to 15, can't use it. Doesn't help you at all, right? And this is basically taking people with PA catheters in place, and which they're getting their PA, wedge pressure, and then they're also seeing what's happening with the Doppler. All right, last question. 77-year-old woman with known CAD whose status post-coronary artery bypass graft surgery in 2003, scheduled for a rotator cuff surgery. However, because of marginal functional capacity, she undergoes a preoperative stress testing, demonstrating a large area of septal ischemia. She subsequently admitted for left ventricular, for left-sided cath, coronary angiogram the next day. Overnight, she complains of somewhat atypical right-sided chest pain and is given sublingual nitro, after which she rapidly becomes unresponsive. Tele shows junctional bradycardia and hypotension. Subsequent angiogram reveals patent bypass grafts and diffuse distal LAD disease after lima, after a lima anastomotic site, but is deemed not suitable for revascularization. Her transthoracic echo is done here. In patients, let me see here. In patients with this grade of diastolic dysfunction, why are nitrates a therapy likely to cause hemodynamic abnormalities? So these patients are extremely preload dependent, so venodilation associated with nitrate use can often result in leftward shift of the Frank-Starling curve, resulting in decreased cardiac output. Reduction in afterload results in elevated LVEP. Coronary vasodilation following nitrate administration leads to diffuse myocardial ischemia and subsequent decreased stroke volume. And in nitrates, because they are endothelium dependent, mediated smooth muscle dilators typically lead to more profound arterial hypotension in patients with known vascular disease. So let's say this patient, what do we think about this patient? This patient has what looks like advanced diastolic dysfunction, right? Based on the history that we're seeing. So why do patients with advanced diastolic dysfunction often get hypotensive with nitrates?
Because they're preload dependent.
Right, they're preload dependent, 100%. So you have to now push blood across a mitral valve into a stiff ventricle. So you need a high enough pressure in your left atrium in order to expel blood across that. If you drop someone's pressure by putting them on high-dose nitrates, right, you drop that preload, that can cause hypotension. So I had a gentleman who had previous coronary vascular disease, previous CABG, admitted a couple weeks ago for NSTEMI. He had acute onset palpitations at home, checked his blood pressure at home. It was around 110 systolic. He was having associated chest pain with it, so took 3 sublingual nitro, and then took his pressure at home, and it was 70 systolic. So he came into the hospital. I saw him as a consultation in the emergency department, and the question is this guy septic? Is he having a big new MI, right? So what happened is he was cardioverted, right, to normal sinus rhythm, and all of a sudden had normal blood pressure, right, after he had some washout of his nitrates. So this gentleman had advanced diastolic dysfunction in the setting of known prior coronary artery disease and ischemic cardiomyopathy, right? Then had new onset AFib and lost that atrial kick, that loss in preload with advanced diastolic dysfunction, and then took nitrates and had further decrease in his preload and subsequently got sicker, right? So this is an example of when you're diagnosing somebody with shock who has potential diastolic dysfunction, you can look at all these hemodynamic parameters, and all the gentleman actually needed was, despite his ischemic cardiomyopathy, I gave him 500 cc's of fluid, cardioverted him, and he never required any vasopressors, right? And that's only because we had some baseline echocardiographic data on him, and he left the ICU within 12 hours. So pretty cool, right? It's a pretty cool case to kind of bring all of these things together. And then lastly, I'll leave you, there's no more questions. Diastolic dysfunction is very complicated, right? Even for cardiologists who are reading echoes all the time, it is a very complex field. I tried to simplify it as much as I can for you. You're going to have to look at this stuff a couple times repeatedly, but if you take it and simplify it as much as possible, know what your mitral valve inflow patterns are, know what your tissue Doppler patterns are and why they look like they do, know your E to E primed variables, and just take a look at those algorithms, and you're going to ace it, no problem. If you understand your pulmonary vein physiology, that's going to also allow you to understand your hepatic vein flow later, so that because they work very similarly. So I think that go through this lecture a couple times, but just try to simplify it as much as possible, and have a lot of respect for diastolic dysfunction when you're taking care of patients with cardiac disease who have hemodynamic instability, because diastology plays a lot more than we actually think prior to looking at our echocardiographic data. Any questions for anybody?
What kind of questions are more sensitive for diastology and RX?
So you're going to see a lot of determination between pseudonormal or grade 2 diastolic dysfunction and normal. You're going to see a lot on filling pressure assessment, right, using your E to E prime. You're going to see some questions on atrial fibrillation and tachycardia and the limitations of using diastolic dysfunction. Those are going to be your main points that you're going to see. So diagnosing it, knowing what grade the person is, and understanding what some signs are for higher or lower filling pressures are really helpful.